Hello, and welcome everyone to the virtual Thalassemia Grand Rounds. I am Billie Lianoglou. This Grand Rounds is a partnership between the Cooley's Anemia Foundation and the Division of Blood Disorders at the U.S. Centers for Disease Control and Prevention, otherwise known as the CDC. I am Billie Lianoglou, and I'm a genetic counselor at the UCSF Benioff Children's Hospital Department of Pediatric Surgery. I'm joined today by Dr. Elliott Vichinsky, who directs the Hematology Oncology at UCSF Benioff Children's Hospital, Oakland. We are both so delighted to be with you for today's virtual thalassemia grand rounds. Today, we will take a deeper look at understanding and treating alpha thalassemia major. We are grateful to the Cooley's Anemia Foundation and the CDC for the provision of continuing education credits in the form of CME, CNE, and CEU. Instructions for receiving continuing education credits will be provided at the conclusion of today's presentation. Some housekeeping items. Before we begin, I'd like to remind everyone that all audio will remain muted throughout the presentation. At the end of the presentation, there will be time for questions. To submit a written question, please use the questions area of the toolbar. We will respond to as many questions as time allows. Today's rounds will last about an hour. Please note that these rounds will be recorded and may be available for future access. Okay, we're going to get into the presentation now. This is Dr. Vichinsky and I, but you can also see us at the top of your screen. Disclosures, neither of us have any disclosures to report. I specifically do not. And Dr. Vichinsky will be discussing different types of transplants, gene option studies, and metabate. The CDC did not accept financial or in-kind support for any ineligible company for this continuing education activity. Learning objectives. So we hope to describe the features of the pathophysiology of alpha thalassemia major. We'll list common complications associated with alpha thalassemia major seen prenatally and also postnatally. We'll describe treatment and management options for patients with alpha thalassemia major, identify strategies the healthcare team can utilize to improve care coordination and outcomes for this disease, and we'll include an overview of the disease, in utero maternal haploidentical stem cell transplantation, and in utero transfusions long-term registry outcomes, including neurodevelopmental assessment results. Start today's meeting by centering the conversation around who we're talking about. So we'd like to center our conversation around those patients impacted by alpha thalassemia major. Our team created a short documentary called Surviving with Joy. This video illustrates, in their own words, the journey of 5 families who received a prenatal diagnosis of alpha thalassemia major and how they navigated the medical care needed to allow for fetal survival. Please start the video.
Say hi.
What flavor is it? Chocolate?
She plays hard just like the other kids do.
When I found out that I was pregnant, the first thing I thought of, how can I surprise Mark with this?
I was really excited. I was like, we're having one more, yes.
We got the diagnosis of alpha thalassemia major, and that was the first time I have heard of the condition.
I was just shocked and confused.
The doctor said, let nature take its course and try again, 9 months from now.
Our thought, of course, was babies don't survive with this diagnosis, with this disorder. That's the information that we got from the doctors, because that's pretty much the information they have.
My doctor was saying, she had heard some things about blood transfusions.
We're like, what is that? We had no idea what that was.
We knew that this is the right course to take to fight for her.
fluid was slowly disappearing. He was growing.
When we delivered her and she took that first cry, I think both of us kind of looked at each other like, oh my gosh, she's here and she's breathing on her own.
Just hearing him cry, it was like everything is here. Everything.
This is the miracle baby. His name is Caleb. First son in Hawaii to have the in utero transfusion.
Hi, this is Oliver. Oliver, say hi.
I would put her inside my shirt. That's how little she was, and would just hug her.
You feel your heart grow. She was this little tiny thing they put right on my belly.
To finally hold my son in my arms, it's such a great joy.
Just waiting for the transfusion to end, but she won hospital bingos.
I'm waiting for my blood to come.
We are in the hospital twice a month for blood draws and transfusions. He says bye to the nurses, blows them a kiss, and says, see you later. He can have this normal life, and that these transfusions are working.
It is by far not a death sentence.
So you never know what's around the corner. Who knows what they're going to come up with in Milo's lifetime.
I just want to make a comment before we start. It's seeing these kids, it transfers the abstract of an alpha thal major into real life. It's really a gratifying and wonderful miracle to see these kids grow up.
Yeah, thank you, Elliott. And I agree. It's been a privilege caring for these families and a joy in seeing them here for you and sharing their stories with you. So we're going to go into now a case that Elliott and I collaborated in the care of. We'll describe this case and the different variables that played a role in the management of this case and summarize in the end, and then we'll go into more detail about the disease and standard of care management. So the patient that we're going to present to you today is a 32-year-old woman. She was seen by her obstetrician prenatally, actually, and both parents were of Filipino ancestry, and they were anxious because they had had a prior miscarriage, and there was also a known family history of thalassemia traits, so they wanted to address both that family history and mitigate the risk of having another loss for a future pregnancy. The patient's OB coordinated a workup, including a complete blood count. The CBC demonstrated that her mean corpuscular volume was low, her red blood cells were small, and also the mean corpuscular hemoglobin, or the ratio of hemoglobin to the red cell volume, was also low, while the red blood cell count was in the normal range. They also performed a hemoglobin electrophoresis, which demonstrated a majority of hemoglobin A fraction, and the patient was then reassured that they're not at risk for thalassemia in spite of their family history. So garnered by this confidence, they decided to move forward and achieve another pregnancy. In that pregnancy, they were surveilled by ultrasound, and the initial findings at the anatomic ultrasound at 18 weeks demonstrated hyperechoic bowel, a small stomach, and also some brightness in the red cardiac wall. So with some concern, they decided to offer the patient prenatal diagnosis and amniocentesis, the family was not interested in diagnostic testing. There was concern both for aneuploidy and some other genetic explanation for these minor findings. So they did cell-free DNA to screen for chromosome number differences like Down syndrome, where you can also see echogenic bowel, and that screening was normal. So they were reassured and told to come back at 22 weeks for follow-up ultrasound. The follow-up ultrasound demonstrated further progression of disease. They saw the heart was enlarged or cardiomegaly. They saw fluid around the heart or pericardial effusion. There was also evidence of fluid in the abdomen or ascites. And they measured the middle cerebral artery, which is the speed of the flow of the blood in the artery of the brain, and they noted that to be elevated. So there was now concern based on the MCV and evidence of effusions that there may be anemia. And the patient was then referred to a high-risk fetal care center in their region. That center performed ultrasound and confirmed the evidence of cardiomegaly and the effusions. There was still higher elevation of the middle cerebral artery at 1.89 multiple of the median, where the normal range should be less than 1.5. And there was also concern about a possible ambiguous genitalia finding. So given this constellation of findings and concern now for anemia, and specifically alpha thalassemia because of the patient's ancestry being a Filipino or Southeast Asian ancestry, the team at this high-risk center presented options to the family. And those options included performing a peri-umbilical blood sampling to test the hemoglobin to confirm anemia, and certainly if anemia were confirmed, to initiate care by transfusing red blood cells. They also discussed the option with the family of termination of pregnancy and or expectant management. With alpha thalassemia major specifically, the concern of expectant management, or the plan for expectant management, is really discouraged in the sense that these patients have risk for perinatal loss. The fetus can demise in utero, but also as the fetus develops hydrops, the mother has risks for mirror syndrome, which can cause edema, or the mother mirroring the symptoms of the fetus. And in addition to the edema and fluid collection of the mother, they can start to develop preeclampsia, and mirror syndrome can be life-threatening for the mother. So we really discourage the option for expectant management. But for those patients who choose not to pursue transfusions and are not comfortable with termination, these patients need to be monitored very closely in pregnancy with a known diagnosis. This patient opted for the option for pubs, where they sampled the fetal hemoglobin, and the pubs did confirm anemia. The fetus had anemia with a hemoglobin of 5.6, and thus they did proceed to transfuse, and 30 cc's of blood was transfused. At the time of pubs, there's always blood that's removed for evaluation in the operating room of the hemoglobin, but also additional blood was sent off to the lab, and hemoglobin electrophoresis was performed and did confirm majority of hemoglobin Barts, which we'll learn about later, which is consistent with the diagnosis of alpha thalassemia major or 4-gene deletion. So the diagnosis was confirmed the next day on the evaluation of hemoglobin electrophoresis, and the family did decide to proceed with transfusions in the pregnancy. They received 6 transfusions in total. The baby was delivered at term over 37 weeks. APGARs were reassuring, 8 and 9. There was about a 2-week length of hospitalization and no need for intubation or mechanical ventilation in this child. So in review of this case, we wanted to talk a little bit and center regarding the guidelines for screening patients at risk for thalassemia. And this is the ACOG practice bulletin, where recommendations include performing a CBC and an RBC on all patients, and then a differential depending on geographic ancestry, where those patients of Southeast Asian and Mediterranean ancestry with evidence of anemia from the CBC irrespective of results of hemoglobin electrophoresis. But if the hemoglobin electrophoresis is normal or not, they need to undergo more targeted testing for alpha thalassemia major in those patients at risk of Southeast Asian ancestry. And so hemoglobin electrophoresis is not able to exclude alpha thalassemia major. It's only able to evaluate for risks for beta thalassemia. And for those patients with a normal hemoglobin electrophoresis and anemia and CBC of Southeast Asian ancestry, evaluation of alpha globin for common deletions of the alpha 1 and alpha 2 gene, in addition to point mutations, is essential for recognizing carrier status and risk in pregnancy. For our patient, she did have evidence of anemia, a Filipino ancestry. In spite of the normal hemoglobin electrophoresis, she really needed a more detailed workup. And DNA-based testing of this couple did demonstrate that they were both carriers of 2 gene deletion, one being the Southeast Asian and the other being called the Filipino deletion, both of which remove the alpha 1 and alpha 2 genes on the chromosome 16. Dr. Vichinsky is now going to talk more about the experience of alpha thalassemia major in the U.S. population.
Well, thank you. Since 2009, California started to note a large increase in the number of alpha thalassemia occurring due to demographic changes from the origins of these cases, which predominantly is in areas of Southeast Asia, China, and several other regions. But with immigration, the numbers were going up so much that we were the first state to initiate universal alpha thal testing in the newborn, which is now being adopted at certain places. This slide reflects the changing immigration pattern, and it makes me think really of how Cooley's anemia was 100 years ago. So this looks at North American immigration by the millions, and you could see that in the turn of the century, there is this very large peak of immigration, and this was in the Greek and Italian US population. Now, and then it subsided, and Cooley's Foundation and leaders developed infrastructure for care in an advocacy way. Then you can see around here in 1961 and we began to see a very rapid change in the immigration to the United States of Asians at risk for alpha thalassemia, and this has continued. The slide on the right is the specific immigration within California, which mimics the marked increase in families at risk from the Asian communities. Oh, go back one, please. So overall, when one would estimate on the data we have for California, which basically we expect 107 alpha thal major births per year, and right now we're not that the alpha thal majors cannot really be quantified at birth, since without intervention they are often miscarriages. And you could see here in California there should be 34. I think these are probably underestimates because of the variables, but this kind of data should be improving. Next slide. This was from a slide of the we run the newborn screening program for hemoglobins for the state, and this was a sample report I did in 2010. We screened 5 million cases, and it illustrates what we found. And basically, everyone's familiar with sickle cell anemia being a primary goal of newborn screening. And you could see here that if you lump in all the sickle cell types, here there were about 930 cases with a prevalence of 17.4 per 100. But if you throw in thalassemia, we start seeing a dramatic change. Look at hemoglobin H. Hemoglobin H is a 3-gene deletion, and hemoglobin H constant spring is a very severe type. And then there are hemoglobin BARTs. You would not expect any BARTs. The reason these were diagnosed was some of them were born not hydropic in stillbirths, or some had interventions. Otherwise, most of them would be missed. And then when you add in the beta thals in with the alpha thals, you can see that alpha thal is a major newborn abnormality in the state of California. And in fact, now the H's and others are equal to the sickle cell births. Next slide, please. Let's just review how we get into a situation with alpha thal in which the fetus does not survive, but in Cooley's anemia or in sickle cell, the fetus is healthy, and you don't hear about the disease until after birth, and the symptoms don't develop in the beta thal mutations until months after birth, so the baby's normal at birth. And that's because in utero, the fetus cannot really breathe. It gets its oxygen from in the placenta as the blood vessel supply from the mother and the baby pass each other. And so the fetus first makes an embryonic hemoglobin, which is able to extract the oxygen off the mother's cells. This embryonic hemoglobin does not have an alpha thal mutation, so it's not affected, and the fetus stays healthy until embryonic hemoglobin begins to change. Embryonic hemoglobin is shut off through regulators, and gamma is turned on. Gamma or fetal hemoglobin remains the major hemoglobin in utero, and gamma is made up of 2 alpha and 2 beta chains. And so when the fetus shuts off the embryonic and starts making fetal blood, it doesn't make effective fetal blood because it doesn't have any alpha. And hemoglobin is sort of a perfect balance on a seesaw. You have to have the same number of alpha chains and the same number of beta chains. So they have to be an equal. And in alpha thal diseases, you don't have the alpha chains. So the non-alpha chains, they sort of float around, they don't know what to do, and they lump together and they settle in the cell, and they basically destroy the cell. But more importantly, not only do this cell not survive, this hemoglobin can be counted on a machine, but it doesn't carry any oxygen. If you look on the far right of this slide, this looks at oxygen saturation, and basically what it's showing is the Bart's hemoglobin or the hemoglobin H do not, Laura, can you hear me? I got at my screen, come back. Just went dead when you did something in the middle of the talk.
We can still hear you, Elliott. The oxygen saturation he was showing is for hemoglobin H disease.
I'm not sure I understand.
I'm sorry, I had a slight problem. So basically, the Bart's hemoglobin is all fetal, and it holds on to oxygen and it can't release it. So it has 100% or its oxygen affinity is such that it cannot deliver any oxygen. The problem with that is sometimes when you put it through a machine, it's counted as hemoglobin, but it doesn't work. And so the fetus, starting when embryonic hemoglobin begins to shut off, develops this severe anemia with cells that don't transport oxygen. And that's when the hydropic changes begin to happen, basically because the fetus has no functional hemoglobin. And those that do survive, in general, have a remnant of the embryonic, a tiny amount that keeps them alive. So I hope that explains that. Then go back one quickly. Now, alpha thal syndromes Is this the first one? All right. Alpha Thal syndromes are really the most common single mutation worldwide. There are about 5% of the entire world are carriers for alpha thal, and it leads to a decreased production of the globin chain. There are many types of alpha thal. Some are less serious than others as carriers. And it, like beta thal or sickle cell, it is particularly effective against malaria, so its origins often overlap where other kind of hemoglobinopathies occur. Now, on the right, you can see chromosome 16, and basically, alpha thal has 4 genes, two on each chromosome. So a single gene affected, the alpha plus, you have 3 working. A single gene mutation clinically is asymptomatic, and the CBC, the routine CBC, will not show microcytosis. Alpha thal minor is when you have 2 of the 4 genes missing. And in that case, you have a mild anemia, and it could be within a normal range, often is, and the cells become smaller, but the number of red cells increase, and you're also asymptomatic. An important point is that if you inherit these 2 missing genes on the same chromosome, as you see in the bottom, that's called cis. You can also inherit a single gene mutation on the opposite chromosome. And that's very important because when you pass it on to your children, if you have them in cis where they're on the same chromosome, then your fetus is at risk for alpha thal major. And this is the main reason why African Americans or Africans who have a very high rate of alpha thal don't get high drops because they're in the translocation. Hemoglobin H is a disease in which 3 of the genes are missing. Now, generally speaking, hemoglobin H is an anemia, and they have problems as they get older, but they do relatively well. But you could have a mutation in one of them, a type of alpha thal mutation, which is an abnormal structure like constant spring that can convert hemoglobin H into a very serious type of hemoglobin H, often resulting in the need for transfusions. Finally, you have all 4 genes missing, and in that case, you don't make any effective blood in utero, and that's what we're talking about. Next slide. Now, yes, so alpha thal, to understand, you could have a trait, everything's fine. In the newborn, you will see a little bit of Bart's, and you can have a deletional hemoglobin H. That's when you have 3 genes missing due to a deletion. They do relatively well. Most of them don't need transfusions, and they grow up into adulthood. They do have problems when they get older, a little bit with iron overload, splenomegaly, and anemia. About 20% of the hemoglobin H's inherit a non-deletion, like hemoglobin constant spring or Quam. This non-deletion increases the severity of hemoglobin H, and those cases often require transfusion in a way due to acute anemia, often stimulated by a viral infection because the hemoglobin is somewhat unstable. And finally, you could have hemoglobin H itself cause high drops. Those are the hemoglobin H's that inherit one of the H not being a deletion, but a very abnormal structural one like constant spring. So not every alpha thal, not every high drops is due to alpha thal major. That's important to know because the hemoglobin H high drops after birth can get better and become not ill. And finally, you have the alpha thal major, the one we're talking about. These are all proportional to the amount of Bart's that you would see. Now, the disease, when you have all of them missing, is due to the fact that you just don't make enough hemoglobin to transport oxygen. And it leads to edema and heart failure and then organs increasing. And when it occurs very early, it can cause other problems, including, because of hypoxia, the risk for anomalies. You could see that Bart's causes a severe anemia. It doesn't deliver oxygen to the tissues, so they can get damaged. And the fetus usually dies in the second or third trimester. Those that survive, as indicated on the slide, in the third trimester are because they have a remnant of the embryonic hemoglobin, which is related to the type of mutation they have. So people see these pictures and it's related to the heart failure, the attempts of the body to make healthy blood. So blood is being made in other organs and trying to grow. You get anomalies in about 17% of the cases, sometimes significant, often not, because of hypoxia to those organs. And you have a massive placenta, and the mother has a very high rate of preeclampsia and mortality if left unobserved. Thank you. And the Doppler, which Billie went over, is very simple. It's sort of the same kind of principle we use to train sickle cell patients. You take the Doppler, you put it over the head, and it reflects the flow in the big blood vessels of the circle of Willis. And when the flow rate is very high, that indicates that there's anemia. And that has turned out to be a very reliable way to determine if there's significant anemia, and it's non-invasive, easy to do. And you can see in the curve that the forms here on the middle cerebral artery is now a standard for all obstetrics to do if they choose to, and it's important to do frequently in questionable cases. Next slide. Do I do this one or you? I don't even remember.
I'm taking care of it.
Okay.
Oh, no, this is you, Elliott. I'm
Okay.
sorry, I thought you meant.
A little marker. All right, so here we are again, and this is just summarizing the point I was making. The fetus lives on fetal hemoglobin, and you could see that fetal hemoglobin requires alpha chains, and since an alpha thal major doesn't make alpha chains, it cannot make functional hemoglobin, and all you have are gamma chains that clump together and they don't transport oxygen. So in reality, the fetus cannot deliver oxygen. This results in severe fetal hypoxia with a massive swelling of organs, basically due to heart failure and other side effects of severe hypoxia. And the options one has is termination, a planned discussion with termination. Other used is expectant termination. In other words, leave the pregnancy alone, but as Billie pointed out, that has serious risks to the mother. And finally, you can do in utero transfusions, which was a technique used many times when the RH disease was very common. After birth, if the fetus is transfused in utero, you can prevent these kind of complications if transfused effectively. But then after birth, they still have the disease. And after a month or two of adjusting, they become basically beta thal major type individuals requiring chronic transfusions with overload being a potential. So transplant is an option like within beta thalassemia. The problem with transplant for this population is finding a match. It's hard to find a match. In addition, the baby has to be exposed to toxic chemotherapy in order to let the graft engraft and to allow it not to be rejected. And finally, because of that, there's a significant risk of complications, including mortality and graft versus host disease. And so these are the issues that one needs to discuss. An issue that we will talk about later is the concern that has been that if they do live high and were transfused, the problem of postnatal problems like neurologic handicap. So so our group over the years and started I basically started transfusing fetuses because the family sought me out on the web page, and after hearing from their OB the recommendations of termination or expected, they wanted to know if there were other options, and with informed understanding, these families made their own individual personal decisions about life and the potential for side effects, and elected to have transfusions. And when that was done, we began to collect an increasing number of clinically transfused pregnancies and their outcome. And there have been a number of other reports, and this is one of the first ones we did. Other ones have been done that vary in their outcomes, that basically they all demonstrated that the outcome would be much better and the baby can be born and many do well. But the problems with these retrospective other studies was that the transfusions count was so variable in these cases. Many of them had only one transfusion, and therefore evaluating their outcome was more difficult and at more risk. In our present study, the protocol requires sustaining a functional level of hemoglobin, and that is a difference. But the largest study in the past, which was reported, did find surprisingly, even with minimal transfusion, that the alpha thal babies were surprisingly neurologically more intact than one was reported to be. And this is summarized on the neurodevelopment chart, but even with inadequate transfusions, their cognitive function was much better than expected. Go ahead. So this was a recent paper, and I wanted to include a few other things because we, after having a meeting with international sites who have high frequencies, have now, as a international groups, have moved into intrauterine transfusions and outcomes. And I just selected a couple of them. This is one recent paper that came out and looked at antenatal transfusion, and you could see that these are 3 cases, aged 12, 5, and 5 now, who got their first transfusion at 20, 21 weeks, got 2 transfusions or more, were born 32 to 37 weeks, were then put on chronic transfusions, and then eventually went through a unrelated transplant, and you could see that they are neurologically normal and free of transfusions, except for one who gets partial transfusions. Hypospadias was noted, and in fact, all males do have hypospadias, and we're not really sure why, whether it's a genetic linkage. Next slide, please. I think that's.
So our group sought to define more rigorously the impact of in utero transfusions on fetuses with alpha thalassemia major for their long-term outcomes. And I'm going to briefly present that data, and then we'll go into the postnatal management. Our registry had a total of 60 patients, 49 of whom were diagnosed prenatally, 11 diagnosed after birth. Of the prenatal diagnosed group, 30 pursued termination of pregnancy. And we have 2 different scenarios. We have those patients that received 2 or more transfusions. They were diagnosed prenatally and remain alive, and there are 14 of those. And then also in this prenatally diagnosed group, there are those patients that chose palliative care, expectant management, or had 0 or 1 transfusion. All of those are now deceased. In the postnatally diagnosed group, there's 11 all alive and diagnosed after birth. Just to highlight, demographics are consistent with what we've talked about as far as primarily Southeast Asian ancestry in the cohort. And the presentation in pregnancy helps understand how we see these patients, the majority of whom presented with high drops, demonstrating fluid around the heart and in the abdomen, and also elevated cardiomegaly or large cardiothoracic ratios. Other features seen on ultrasound included amniotic fluid abnormalities, echogenic bowel, like we discussed, and ambiguous genitalia, which in the end may be hypospadias postnatally. For the outcomes, we were really encouraged. We saw for those patients defined optimally transfusion as 2 or more transfusions, resolution of high drops was in 100% of those cases, as opposed to those who had 0 or 1 transfusion. Also, gestational age at birth was late preterm or term deliveries, statistically significantly different from those that received 0 or 1 transfusion. And then length of hospitalization was also statistically significantly shorter. This work was done in collaboration with Marissa Schwab, who was a surgery resident in Dr. McKenzie's lab. We evaluated neurodevelopmental outcomes using the Vineland Adaptive and Behavioral Scale. And here we're graphing the composite percentile score. Composite score for the Vineland includes subdomains added together of communication, daily living skills, and socialization. And this is graphed against the gestational age at which first transfusion were initiated. The filled circles are those patients that had received in utero transfusion. The open circle is a patient that was born and did not receive in utero transfusion. They were diagnosed after birth. Triangle is a patient of hemoglobin H Adana. And what you'll see is a linear correlation between those receiving in utero transfusions earlier in gestation having a higher composite score. These lines represent the 50th percentile, 1 standard deviation from the mean, and 2 standard deviations of the mean and lower represent patients at risk of intellectual disability. And so all patients measured had average scores and were not at risk. This supports to us really encouraging data that patients with alpha thalassemia major, when transfused in utero and that are bridged to delivery, really are the same as patients after birth with beta thalassemia major. And we've talked about those considerations in terms of how they're managed and the opportunities for stem cell transplantation. We're running a little short on time. We had some tech issues that started, so I'm going to try to breeze through these because there are some key points I think that are important. Our group sought to look to improve the management of this disease by exploring the opportunity for in utero stem cell transplantation, that being using the mom as a donor, and that would mitigate some of these risks of stem cell transplantation after birth in terms of identifying a donor and concerns about toxic preparation for the bone marrow transplant. So that is predicated on the notion that the maternal and fetal cells traffic and the fetal immune system operates differently than the child or the adult. So when a fetus is exposed to a maternal cell or a protein, their naive T cells become regulatory T cells, which are the foundation of induction of tolerance, as opposed to effector T cells, which are those T cells that mount an immune response. And from this early work by Mold et al., it was recognized that the mom could serve as a perfect donor. Here's just a quick picture about what happens when we underwent this protocol. 300 cc's of maternal bone marrow were harvested, and selected CD34 cells, which are the precursors of red blood cells, were selected out and given T cell add back. Those stem cells were transfused first, and then red blood cells were given. This is an ultrasound picture of that. And here you see Dr. Juan Gonzalez, our MFM, performing the procedure and pushing the stem cells, and later red cells would be given. And in summary, we transplanted 6 patients, 4 presented with high drops before the initiation of care, 2 never developed high drops. And with the transfusions, high drops resolved. We were able to obtain our goal of maternal stem cells, and we learned a lot from this study. We learned that preterm labor was not observed in these patients. They had short NICU stays. There was no evidence of graft versus host disease, and normal neurologic testing at 1 year for 5 of the 6 patients. 1 of them was just born a few weeks ago. We have seen low engraftment, and just 1 of the patients had sustained tolerance to the maternal cells. We also looked at fetal brain or postnatal brain MRIs, and Elliott can summarize briefly that evidence of the iron storage, and then we'll move on and have an opportunity to wrap up for questions.
Go back one slide, which is more important. Oh, maybe go one more slide forward. Forward one slide.
Sorry, I'm trying.
Okay.
The system's a little slow.
I'm only going to do one, so I'll quickly summarize.
Oh, you mean forward. I'm sorry, Elliott.
Yeah. Yeah, for me. All right, maybe the other, yeah, this one. Okay, so after birth, there's a kind of a transition where they have to be monitored and transfused more often. And it's like a beta thal major, but there's some difference in that. The alpha thal patients, the Barrett's hemoglobin is counted as hemoglobin when you do a CBC. So the CBC may come back and say the hemoglobin is 10, but if the Barrett's level is 50, the functional hemoglobin is 5. And so that if you don't correct the anemia or the hemoglobin after birth, the fetus remains functionally anemic, and it keeps turning on the bone marrow to make more alpha thal cells. So the physician has to compensate by that by raising the total hemoglobin to a higher level, let's say 11 or 12, to shut off the bone marrow so it doesn't make the Barrett's hemoglobin. Once it does that, then the fetus hemoglobin will be functional. But if they don't do that, it will continue the disease. And it's easy to correct by that formula I told you. So this just quickly shows that the differences in alpha and beta thal in some of the measurements in terms of liver iron versus a ferritin, and in which you need to do an MRI because the ferritin may be less accurate. But when you transfuse the the newborn accurately to the higher number I told you, then the ferritin bounces back to be normal. If you don't, it disproportionately is a low inaccurate number. So if these patients can be monitored after the first 4 to 6 months and transfused like a beta thal, and then the options for them after beta thal is the same. And this just shows a nice work by Amid that shows in the standard transfusion that they have a very active bone marrow, but when you put them on a somewhat higher transfusion regimen, all the markers of marrow activity go back to normal. Next slide. I think I didn't show, yeah. And I'm gonna skip over the brain slide, but I was worried that iron could cross the blood-brain barrier due to so many transfusions and create iron deposition. But in a preliminary study we've been doing with quantitative brain iron, we did not see any increased iron, and the blood-brain barrier was intact. So in summary, I think this is a critical juncture for the future of pregnancies involving alpha thal. You really do have to have preconceptual screening, prenatal testing, monitoring of the fetus, and serial transfusions. And then the family can be offered options and close monitoring of the Barrett's and the hemoglobin A, and then a decision for the future. We are working now collaboratively with multiple sites, and we're optimistic.
Yes.
We're done. Oh,
yeah. So this is just a recognition of the work we've been doing and collaborating with other experts around the world. We had an international consortium. We published a consensus statement supporting the value of offering in utero transfusions when feasible for fetuses affected with alpha thalassemia major. And we have so many remaining questions that should be answered, including how to optimally transfuse for this disease, when to start iron chelation, the optimum transplant protocol for this disease, and if we can still do better. And so I won't get into it too much, but we do want to develop new therapies and cures for this disease, including the development of gene therapy, harnessing the notion that some of these deletions that do overlap with the zeta globin gene on chromosome 16, we're noticing a more severe phenotype. And so from our cohort, we had about a third of those that had zeta globin completely deleted, as opposed to the postnatals where there was no patients that had zeta globin deletion. And that is an opportunity to say, well, can we use zeta globin as a treatment opportunity? And so we do have a grant also funded by the CDC and NIH, and we're looking at 3 different approaches to develop a curative therapy for this condition, including upregulation of embryonic zeta globin, restoring alpha globin expression via gene editing, and then also alpha globin gene replacement. And these are with collaborators at UCLA, Don Cohn, Dr. Kyle Cromer here at UCSF, and Dr. Tippy McKenzie. So I think we'll end here. Hopefully you got the highlights of alpha thalassemia, where we were, where we are, and where we hope to go. And please feel free to put any questions in the chat.
Well, one comment I didn't get a chance is that we are doing detailed neurocognitive testing on the babies that were born, and everyone at 1 year really was in a normal right range. And our long-term data from the retrospective study also shows the children are in mainstream school and in general in their correct grade. Thank you.
Thanks, Elliott. There was a question about that slide that we briefly hit on as far as optimizing transfusion for alpha thal to shut down the ineffective erythropoiesis. And the question is whether or not, or why with aggressive transfusion, only increasing the hemoglobin by about 1 gram per deciliter is enough.
It varies. It's a kind of a formula based on how much BARTs they have. So it's really calculating individually how high you have to get them. And you can monitor that by, in the first month, by how many nucleated reds they're putting out, how active the bone marrow is. The real goal of the guide is to shut their bone marrow off. In general, once they're stabilized in our program, they'd only need 1 gram above the standard to stay that way. But in the first month, it's kind of a lot of things are changing, and they often need more frequent transfusions so they don't drop down. But if you keep them above around 12 in the first month, they will shut off.
Thanks, Elliott. There was also a question about if in utero gene therapy is a consideration, and perhaps that was asked before I presented some of the work that we're doing in developing a gene therapy approach. Most likely this would be a postnatal approach, in the sense that currently the technologies are really most amenable to ex vivo gene editing, but certainly the goal would always be that can we treat still earlier and moving towards an in utero gene therapy approach of somatic cells. So that is something that our group is exploring, absolutely. There was also a question regarding whether or not a diagnosis of alpha thalassemia major is required to initiate in utero transfusions. And hopefully from our case, it was appreciated that evidence of anemia is enough to start working up and evaluating and addressing the fetal anemia. And actually the last slide that we have is highlighting those key points that preconception, early pregnancy identification carriers is really critical. But if you're already seeing high drops, like with our case, consideration of pubs and initiation of transfusion for those families that are interested in pursuing active fetal management is really critical, because you don't want to prolong the hypoxic state by waiting for a molecular diagnosis, which can take many weeks.
A key point here is the lack of preconceptual counseling. In reality, every couple should have testing to know what the potential is during their pregnancy. The ultrasound or testing does give you a window into development of the heart failure and the other problems, but it would be so much easier and better if a family before they were pregnant knew what was going on. And the ideal time to transfuse them if they knew what the disease was, would be much earlier than before they got hydropic. So the early, what Billie showed you and maybe switched, the earlier the transfusion, the less morbidity and the better outcomes for the fetus. So it's really important. We've had a number of cases that the transfusion was attempted late in the pregnancy, and that abrogates the real benefit of it completely. So preconceptual diagnosis and testing is something we really are trying to work with the coolies and other groups, and especially OB. And we recommend all the families get tested on their own.
Elliott, there's a follow-up question related to that, and that question is that for patients that they see of high-risk geographic ancestry, do you recommend to do genetic testing for thalassemia regardless of the CBC outcome? So as in some mutations, they may not have hyperchromatic microcytosis.
In general, if you're not anemic and you don't have microcytosis or abnormalities, in general, we don't recommend that you have to have it. You can have a single gene mutation that would be totally missed and have a fetus that has hemoglobin H disease. Hemoglobin H disease is not a disease that requires the consideration, in my opinion, of abortion or severe disease, and unless there's an abnormal structural protein that would be found. So this has come up a lot, and there are rare cases, but I don't think hemoglobin H disease, which makes up the deletions, makes up most of them, is worthy of, in general, of being looked at as other options. Though I feel in terms of genetic information, it would be helpful to know if you are a carrier of a single gene. I must mention one other thing about that, because these regions all live together. So the alpha thal is often in the community of beta mutations. So many families could inherit a beta mutation, a hemoglobin E, a beta trait, or sickle trait. And so that about a third of people with beta thal traits have an alpha thal deletion, so that's important to keep in mind. We no longer in our reference lab do testing for alpha or beta. We always include both because of this the inheritance of both of them together. The good news is that usually the alpha and beta cross each other out by causing less disequilibrium in the number of chains made, but I do recommend that both sides be tested when you go down the road to DNA testing.
Thanks, Elliott. I think maybe we have time for one more question, and there are a lot of questions that were asked in the chat, so I'm sorry if we haven't gotten to address them, but Dr. Vichinsky or I would be happy to correspond by email. How about exchange transfusion to reduce the hemoglobin further? What are your thoughts on that, Elliott?
That's a good question. And in fact, it's in our protocol, we did not use it. There are sites that have done it, and it depending on the fetal, but one, depending on their comfort with doing it, two, and the risk, and two, the how the fetus is doing at that time. It is not wrong to do it in the right hands, but it should be done by program. So it is an option, and it can be considered in selected cases. We have not found it necessary, but it is a viable option in specific in cases, as cases should be individually managed.
And that brings us to the hour. We're grateful for everyone's attendance and attention, and we're grateful for the CDC and Cooley's Anemia Foundation for the opportunity to present our work and this platform to reach all of you. So we hope you have a wonderful afternoon. Thank you so much.
Yeah, thank you for listening. Are we on?